Picture this, a man named Gerald. He's 72 years old, retired, sharp as a tack. He goes into the hospital on a Tuesday for what his doctor calls a routine procedure, nothing emergency, nothing dramatic. He feels fine going in. The nurses are kind. The paperwork is standard. He signs what they hand him, because that's what you do. 4 days later, Gerald goes home. He recovers well, and then about 3 weeks after discharge, the bills start arriving. One is from a surgeon he never met, an out-of-network specialist who assisted in the procedure without Gerald's knowledge. One is from the hospital for his entire stay, not covered by Medicare the way he expected, because it turns out Gerald was never formally admitted as an inpatient. He was classified as something called observation status. And because of that one classification, Medicare won't cover the rehabilitation facility his doctor recommended. Gerald did nothing wrong. He asked reasonable questions. He followed every instruction. But nobody told him the 5 things that could have protected him. And by the time he understood what had happened, the window to appeal had already closed. My name is Dr. William Parker. I've spent 21 years specializing in senior health. And what I'm going to walk you through today are those 5 things. 5 hospital and Medicare traps that catch seniors every single year, not because they're careless, but because nobody explains the rules clearly enough before it matters. Stay with me through all 5. Trap number 4 is the one most people never think to ask about. And trap number 5, the one about how hospitals classify you, is the most financially consequential thing I cover on this entire channel. It only makes sense once you understand what comes before it. If this channel is new to you, subscribe now. This is what we do here. Calm, clear guidance for adults who want to understand the system before the system makes decisions for them. Let's get into it. Before I give you the 5 traps, I need to give you one framework first, because without it, the individual traps won't fully connect. I call it the assumption gap. And it's the reason Gerald's story happens thousands of times every single day across this country. Here's what changes about your relationship with the healthcare system after 65. 3 things specifically. First, the rules become more complex, not less. Most people assume that once you're on Medicare, coverage is straightforward. In reality, Medicare's rules around hospital admissions, observation status, and post-acute care are among the most complicated in the entire U.S. healthcare system. What you don't know genuinely costs you money. Second, the paperwork you sign carries more weight than you realize. Admission documents at most hospitals contain financial clauses that most patients never read and that most staff never explain. Signing without understanding can legally transfer financial responsibility to you for costs that might otherwise be disputed. Third, and this is the one that connects everything, hospitals and insurers operate inside a system designed around their interests, not yours. That's not cynicism. That's how the incentives are structured. The assumption gap is the space between what most seniors believe their coverage includes and what it actually includes under specific conditions. Every trap on today's list lives inside that gap. Keep that framework in mind as we go through each one. Now, I want to ask you something. Think back to the last time you or someone you loved dealt with a hospital stay or even an ER visit. Do you remember how fast the paperwork moved? How quickly someone put a clipboard in front of you? How little time there was to read anything carefully, let alone ask questions? Most people I talk to describe the same experience. You're focused on the health situation. You trust the institution. You sign what they hand you and assume that's the right thing to do. Nobody pulls you aside and says, here are the 5 things you need to ask before you agree to anything. If any of that sounds familiar, this video was made specifically for you. Here's what I need you to understand before we go any further. The financial and coverage problems that follow hospital stays for seniors are not inevitable. They are largely preventable if you know the right questions to ask at the right moments. The rules exist, the protections exist. Federal law gives you rights inside that hospital that most people never exercise, simply because they didn't know they had them. That's what today is about. Not fear, not doom, practical knowledge that puts you back in control. Before we go deeper, if you want a written guide that maps out these protections and questions in one place, I put together a free resource linked in the description below. It's called the Longevity Guide, and thousands of people in this community are already using it. Grab it now and follow along. Let me explain something about how hospitals and insurers process patients, because once you see this clearly, the 5 traps make immediate sense. When you arrive at a hospital, 2 separate systems activate simultaneously. The clinical system, doctors, nurses, treatment, is focused on your health. The administrative system, billing, coding, classification, is focused on how your stay is categorized for payment purposes. These 2 systems do not always communicate well, and the category your stay gets assigned to, often within the first few hours of arrival, can determine tens of thousands of dollars in coverage outcomes. Think of it like checking into a hotel. Whether the front desk logs you as a standard guest or a conference attendee changes which services are included in your rate. You're staying in the same room, you're getting the same breakfast, but the billing is completely different, and nobody at the front desk is required to explain the difference unless you ask. That's the system you're navigating every time you or someone you care about enters a hospital. A report from the Office of the Inspector General found that Medicare patients who were placed under observation status rather than formally admitted faced an average of $7,000 more in out-of-pocket costs per hospital stay compared to those formally admitted as inpatients. That's not a billing error. That's the system working exactly as designed. Now, here's what I've found in 21 years working in this space. There are 5 specific traps inside that system that seniors encounter most frequently and most preventably. I've ordered them from common to most critical so you know where to focus your attention first. The last one affects more people than any other item on this list, and the financial consequences can be devastating. But you need to understand the first 4 to fully appreciate why. Let's start. Trap 1. Out-of-network surprise bills. When Barbara was 68, she had solid Medicare coverage and a supplemental plan she'd carried for years. She went in for a planned cardiac procedure at an in-network hospital, asked the right questions about her surgeon, confirmed he was in-network. 3 weeks later, she received a bill for over $4,000 from an anesthesiologist she had never met and never chose, someone who assisted in the procedure and was not in her network. Most people assume that if the hospital and the primary physician are in-network, everyone involved in their care will be. That assumption is wrong. Hospitals routinely use contracted specialists, anesthesiologists, radiologists, pathologists, surgical assistants, who maintain their own separate network agreements. These providers can bill independently, and in-network status for the hospital does not extend to them automatically. Third, the No Surprises Act, which took effect in January 2022, provides federal protection against many of these bills. Under this law, for most planned procedures, out-of-network providers cannot bill you more than your in-network cost-sharing rate without your explicit written consent in advance. The key word is explicit. If you sign a general financial consent form without realizing it contains a clause waiving your No Surprises Act protections, that waiver can hold. The practical guidance is this. Before any planned procedure, ask the hospital in writing for a list of every provider who will participate in your care. Ask specifically which of those providers are in your network. If any are out of network, ask whether you can request an in-network alternative. And if you're asked to sign any document consenting to out-of-network billing, read that clause carefully before you sign it. The common mistake is assuming that a signed general consent form doesn't carry specific financial implications. It often does. Any form that includes the phrase financial responsibility or non-participating provider deserves a careful read before your signature goes on it. If you receive a surprise bill after a procedure and believe the No Surprises Act applies to your situation, you have the right to dispute it. The federal No Surprises Act dispute process is available through CMS, the Centers for Medicare and Medicaid Services, and your insurer is required to provide information about how to initiate it. Within the first 30 days after receiving a bill you believe is incorrect, contact your insurer and request an itemized statement. Document every call. The earlier you raise the dispute, the more options you have. Now, Trap 2 is one that catches people in a completely different moment, not when the bill arrives, but when the hospital tells you it's time to go home. Trap 2, Premature hospital discharge. Harold was 74. He'd been admitted after a fall that resulted in a hairline fracture. After 3 days, a hospital administrator, not his physician, informed him that his insurance would stay through the following morning and that he should plan to be discharged. Harold felt unsteady. His pain wasn't well controlled, but he assumed that if the insurance said it was time to go, it must be medically appropriate. He was discharged. He fell again at home 2 days later. Here's what Harold didn't know. Medicare beneficiaries have the legal right to appeal a hospital discharge decision before leaving the same day if necessary. This is not a complaint process. It is a formal federal right. It is called a Quality Improvement Organization appeal, or QIO appeal. Every Medicare patient must be given a written notice called the Important Message from Medicare, which explains this right before discharge. If you were not given this notice, the hospital is out of compliance. A study from the Commonwealth Fund found that approximately 1 in 5 Medicare patients is readmitted to the hospital within 30 days of discharge, and premature discharge is one of the most frequently cited contributing factors. Readmission carries its own set of costs, risks, and coverage complications. The practical guidance is this. If you or a family member feels that discharge is happening before it is medically safe, request the QIO appeal immediately. You do not need a lawyer. You do not need your doctor to agree with you. You call the QIO. The phone number must be on the Important Message from Medicare document and request a review. Medicare will pay for your continued stay while the appeal is reviewed. The hospital cannot discharge you during that review period. The common mistake is waiting until you're already home to raise the concern. Once you leave, the appeal process changes significantly and your options narrow. The time to act is before discharge, not after. Quick pause here. Have you or someone in your family ever felt that a hospital discharge happened too fast? Drop a yes or no in the comments. In my experience, this is far more common than people realize, and the people who successfully appeal are almost always the ones who knew this right existed before they needed it. Trap 3. Medication substitutions during your hospital stay. Ruth was 71. She took 4 medications daily, ones her doctor had carefully selected and adjusted over several years. When she was admitted for a knee replacement, the hospital substituted 2 of those medications with alternatives from their own formulary, which is the hospital's approved list of drugs. Nobody asked her, nobody explained why. She assumed the hospital knew best. After discharge, she experienced side effects she hadn't had before and spent 2 months working with her doctor to restabilize her regimen. Here's what most people don't know. Hospitals maintain their own formularies, approved drug lists, and when your regular medication isn't on that list, they will often substitute an alternative without specific patient consent beyond the general admission paperwork. This is standard practice. It is also legal, but it creates real problems when the substitute behaves differently in your body, interacts with other medications you take, or creates a transition challenge at discharge when you return to your original regimen. A report published in the American Journal of Health System Pharmacy found that medication discrepancies at hospital admission affected a significant portion of older adults, particularly those on 5 or more medications, and that these discrepancies were a leading cause of adverse drug events during and after hospitalization. The practical guidance is this. Before any planned hospital stay, write out a complete medication list. Every drug, every dose, every frequency, including over-the-counter medications and supplements. Bring that list with you. When you're admitted, give it to your care team and ask specifically, will any of these medications be substituted during my stay? And if so, can you explain the rationale and how we'll transition back at discharge? You have the right to ask. You have the right to involve your own physician in that conversation. The common mistake is assuming the hospital's pharmacy team is automatically coordinating with your regular doctor. In many cases, they are not. The handoff is your responsibility to initiate. This is not medical advice. Your specific medications and medical history require a conversation with your own physician. But the habit of bringing a complete written medication list to every hospital encounter is one of the most protective things you can do. Now we're going to shift gears. What I'm about to cover next is the part of the hospital experience that most people never think about until it's already happened to them. These last 2 traps are where the real financial exposure lives. Trap 4, financial responsibility forms buried in admission paperwork. Most people know they'll be asked to sign paperwork when they're admitted to a hospital. What most people don't know is that those documents often contain financial clauses that go significantly beyond standard consent to treatment. Martin was 69. He was admitted through the emergency department after a cardiac event. Understandably, he was not in a position to read carefully. He signed everything quickly. Among the documents was a clause agreeing to be financially responsible for any charges not covered by his insurance, including charges that arose from coverage disputes. 18 months later, when his insurer denied a portion of his claim, the hospital used that signed document to pursue him directly for the balance. A 2021 analysis by the Kaiser Family Foundation found that more than half of American adults reported difficulty affording healthcare costs, and that surprise billing and unexpected out-of-pocket charges were among the most commonly cited sources of financial hardship. For seniors on fixed incomes, a single unexpected hospital bill can represent months of income. Here's what you can do. If you have any capacity to review admission paperwork, or if a family member or advocate is with you, look specifically for language about financial responsibility, assignment of benefits, and non-covered charges. You are allowed to ask questions before you sign. You are allowed to cross out or annotate specific clauses. Write, "I do not agree to this clause" next to any language you're uncomfortable with, and initial it. This does not guarantee the hospital will honor your annotation, but it creates a documented record of your objection that can be relevant in a billing dispute. If you are admitted through an emergency and cannot review documents in advance, you can request a copy of everything you signed once you are stable, and you have the right to dispute charges that arose from clauses you were not in a position to review. The common mistake is assuming that because you signed something quickly under duress, you have no recourse. That assumption is not always correct. Many billing disputes are successfully resolved after the fact, but they require documentation and persistence. Now here it is, the trap that changes the conversation entirely, and it is the one that connects directly back to Gerald's story at the beginning of this video. Trap 5, observation status versus inpatient admission. This is the most misunderstood and most financially consequential classification in Medicare. And I want to explain it clearly because the details here matter enormously. When you arrive at a hospital and a physician orders you to stay, you and your family will almost certainly assume you have been admitted as an inpatient. In a significant number of cases, you have not. You may have been placed under observation status, a classification that means under Medicare's rules. You are technically an outpatient receiving extended monitoring, even if you are occupying a hospital bed for multiple days. The practical difference is staggering. Under Medicare Part A, inpatient admissions cover your hospital stay and, critically, make you eligible for post-acute rehabilitation coverage at a skilled nursing facility, provided you meet the 3-day inpatient stay requirement. Under observation status, none of that applies. Your hospital stay may be billed under Medicare Part B instead of Part A, often at higher out-of-pocket cost. And you are not eligible for covered skilled nursing facility care, regardless of how many days you spent in the hospital. A report from the U.S. Government Accountability Office found that the number of Medicare beneficiaries placed under observation status for more than 48 hours increased by over 96% between 2006 and 2014, and that many of these patients were unaware of their classification until they received the bill. The financial consequences for those who needed post-acute rehabilitation care were severe, with some patients facing skilled nursing facility costs of $500 or more per day that Medicare would not cover. The Notice of Observation Treatment and Implication for Care Eligibility Act, known as the Notice Act, requires hospitals to notify Medicare beneficiaries in writing within 36 hours if they are under observation status, rather than admitted as inpatients. That notification is called the Medicare Outpatient Observation Notice, or MOON. You are entitled to receive it. If you don't receive it, ask. The practical guidance is this. Within the first 24 hours of any hospital stay, ask your nurse or care coordinator directly, am I formally admitted as an inpatient, or am I under observation status? Write down the answer and who gave it to you. If you are under observation status and you believe your condition warrants inpatient admission, you or your physician can request a status review. Your doctor's clinical judgment about the appropriate level of care carries significant weight in that review. And here's what to do instead of waiting to find out at discharge. Ask on arrival. Ask again after 24 hours if the answer was observation status. If you're told inpatient requires authorization, ask who is responsible for pursuing that authorization and what the timeline is. The common mistake, and it is the most costly mistake on this entire list, is assuming that if the hospital put you in a bed and kept you for 3 days, Medicare will count those 3 days towards skilled nursing facility eligibility. That assumption has cost seniors and their families hundreds of thousands of dollars in uncovered rehabilitation costs. The question costs you nothing to ask. The answer can change everything. Before I give you your 30-day action step, I want to leave you with something you can use at your very next hospital encounter or give to a family member who might face one. I call it the Hospital Admission Safety Protocol. 5 questions, write them down, put them in your phone. Give this list to whoever is most likely to be with you in a hospital setting. Question 1, am I being formally admitted as an inpatient or am I under observation status? Question 2, can you give me a list of every provider who will be involved in my care today and which of those providers are in my insurance network? Question 3, will any of my current medications be changed or substituted during this stay, and can my own physician be consulted before any changes are made? Question 4, what are my rights if I believe I am being discharged before I am medically ready to leave? Question 5, is there anything in the paperwork I'm being asked to sign that makes me financially responsible for charges my insurance may not cover? Any good hospital patient advocate, social worker, or physician will welcome these questions. And if the response you receive makes you feel that asking was somehow inappropriate, that tells you something important too. Here is your 30-day action step. And I want to make this specific because vague intentions don't translate into protection. This week, not in 30 days, this week, create what I call a hospital readiness file. It takes about 20 minutes. Write down every medication you take, the dose, and how often you take it. Add your primary care physician's name and direct phone number. Add the name and phone number of one family member or trusted friend who can advocate for you if you're not in a position to advocate for yourself. Write down your insurance information, including your Medicare number and any supplemental policy details. And write down these 5 questions from today. Put that document somewhere you can grab it quickly and tell the person you listed as your advocate where it is. That file is your protection. Not because anything bad is going to happen, but because the people who navigate hospital encounters most successfully are almost always the people who were prepared before they needed to be. Check your file in 30 days. Update anything that has changed. I want to close with something that I think about often in this work. There is a difference between a healthcare system designed to treat illness and a healthcare system designed to protect the person. After 65, navigating those two things requires more knowledge than most people are ever given. The traps we talked about today are not the result of malice. They are the result of a complex system that was never designed with the patient's financial protection as its primary concern. The best patient advocates I have ever encountered, and I have worked alongside many, are almost never the ones who are most aggressive or most difficult. They are the ones who are most prepared. They ask calm, specific questions. They write things down. They know their rights before they need them. That is what you now have. You know what observation status is. You know what the No Surprises Act protects you from. You know you have the right to appeal a discharge. You know to read the paperwork before you sign it. And you know to bring your medication list every single time. In 21 years, I have watched that kind of preparation make a real measurable difference for the people I serve. You are not a passive participant in your own healthcare. You are a participant with rights, and today you know what they are. If this gave you something useful, subscribe. That is what this channel is built for. Calm, real, practical guidance for adults who want to understand the system before the system makes decisions for them. I'll see you in the next one.